Drugs and drug addiction can very much function like a virus in a community, is that people need more and more of that drug over time to get the same effect, and more potent versions of that drug to get the same effect. And the reason that methamphetamines can cause a psychosis. Psychosis is when people lose touch with reality. And if you are surrounded by easy accessibility to addictive drugs, you are more likely to try them, and you are more likely to get addicted to them, and you are less likely to be able to get into recovery. Someone can say something is harm reduction, but if there's no evidence to show that it actually reduces harm, then it's not a harm reduction strategy. There is no reliable or robust evidence that safe injection sites reduce harm to the public good. We do that if we force them through some mechanism to get out of that cycle of intoxication and withdrawal. Those individuals will then be able to access their choice mechanisms and then actually choose what they want in their lives. And those individuals will often choose recovery.
Professor Anna Lembke, thank you so much for speaking with me today.
Well, you are very welcome. I'm delighted to be here. My name is Anna Lembke. I'm a psychiatrist and professor of psychiatry and addiction medicine at Stanford University School of Medicine. I teach, I do research, and I see patients.
In recent years, we've heard so much about drug use and drug dealing, especially in inner cities like San Francisco and LA. So first of all, can you just tell us what is this drug called methamphetamine?
Methamphetamine is a stimulant, so it's akin to cocaine, but other stimulants are things like nicotine. And it essentially works by releasing or increasing neurotransmitters like dopamine and norepinephrine in the brain.
I see. So
and these are our stimulating, activating, and reinforcing neurotransmitters.
Is it stronger, more potent than heroin or previous drugs like cocaine?
Yeah, you can't really talk about one drug being stronger or more potent to another drug in a different class, because addiction is the interaction between an individual's brain and the drug they're using and the environment that they're in. Mm-hmm. And there's this whole concept of drug of choice, which is really important, which is that what is reinforcing or potentially addictive for one person might not be reinforcing or addictive for another person. So for one person, their drug of choice might be methamphetamines. For another, it might be alcohol. For another, it might be pornography. So it's this unique sort of locking key between our unique brains and then the key, the drug being the key that we insert, and whether or not it turns our particular lock.
I hear from people who report in San Francisco, and then they see a lot of drug use related to methamphetamine in recent years. And then they're worried this drug is particularly potent and then particularly affecting the younger generation. Do you share the same concerns?
I mean, sure. I mean, drugs and drug addiction can very much function like a virus in a community. Mm-hmm. That once there starts to be a pocket of people using that, there's a market, then suppliers come in, and then it can spread to people in that community. Mm-hmm. So yes, in recent years, very concerning to see the increased rates of methamphetamine use, but also opioids. I mean, opioids are a huge problem, starting with prescription opioids, now progressing to heroin and illicit fentanyl, which is particularly lethal and particularly potent. And you've got the problem of polydrug use, which is actually more common than not in the modern age. That is to say, people more commonly use multiple substances in combination or sequentially. When you combine addictive drugs together, the risk of death goes up. So combining methamphetamines with opioids increases the risk of either of those drugs alone.
Since you said, people, each person may have their own choice of drugs. Do they migrate from sort of less potent drugs, and then that drug can no longer satisfy their desire, and then they move on to the next drug. Is there something like that?
Yes. So the natural history of the disease of addiction is that people need more and more of that drug over time to get the same effect, and more potent versions of that drug to get the same effect. And the reason for that is because the brain adapts to the drug and we develop tolerance. Tolerance is our drug stops working, we need more or more potent forms to get the same effect. One of the ways to increase or overcome tolerance to a drug is to change the delivery mechanism. So for example, to switch from eating the drug or smoking the drug to injecting the drug, because injecting the drug puts the drug right in our bloodstream. As it goes through the blood-brain barrier, the uptake is much faster, and so the potency is greater. But the other way to do it is to get more potent forms of that drug. So for example, fentanyl is an opioid, which is 50 to 100 times more potent than morphine or heroin. Another way to overcome potency is actually to combine two different drugs together. So for example, to combine methamphetamine with an opioid and thereby make both of those drugs more potent in combination. All of these are part of the natural progression of the disease of addiction, in which over time people need more of their drug and more potent forms of their drug to get the same effect.
Do you know something called mass-induced psychosis? And some people say it's easy to confuse that with schizophrenia. So is that right?
Right. So one of the hallmarks of methamphetamines in particular is that methamphetamines can cause a psychosis. Psychosis is when people lose touch with reality, when they either see things that other people don't see, hear things, typically voices that other people don't hear, or have thoughts that are inconsistent with reality. Any of those manifestations counts as psychosis, and those are a classic response to acute intoxication with methamphetamines and stimulants and other stimulants as well. And oftentimes that psychosis can last for a while before it goes away, and it can look exactly like schizophrenia. In fact, substance use is the great mimic for many different types of mental disorders. People who are intoxicated with many different substances can look manic, psychotic. People can look depressed when they're withdrawing. They can manifest other psychiatric symptoms at various phases of intoxication and withdrawal. So really, really important to remember that substances are the great mimic for many different psychiatric disorders, which is why it's so important in the field of psychiatry that we don't make a diagnosis of a psychiatric disorder until an individual has had a period of abstinence from that drug, so that we know for sure they're neither intoxicated nor withdrawing from a drug when we evaluate their psychiatric symptoms. And typically, the minimum amount of time is 4 weeks of abstinence. That's the bare minimum to be able to make an evaluation of a coexisting psychiatric disorder.
Wow. So 4 weeks, and for people who sleep on the street, there's no way they can have that 4 weeks of no drugs in order for a psychiatrist to give a clear diagnosis, right?
Well, I wouldn't want to say no way. I think that underestimates the potential of anybody to get, because I believe that anybody has the potential to get into recovery. I wouldn't want to say, I wouldn't want to not have hope. And so people living on the street, we should be just as hopeful for them to get into recovery as anybody else. But it's certainly true that environment matters, and that the risk factors that come with an environment have a huge impact on the initiation and perpetuation of addictive drug use. And if you are surrounded by easy accessibility to addictive drugs, you are more likely to try them, and you are more likely to get addicted to them, and you are less likely to be able to get into recovery.
That's related to another of my questions, which is this so-called neighborhood effect that you talked about in your book. So do you worry about children and teenagers in San Francisco who probably live near Tenderloin, and they have this constant exposure to open air drug use and drug dealing? Do you worry like that? Is that going to perhaps increase the likelihood of those children and teenagers using drugs in the future themselves?
Well, let me answer that by saying I'm very worried for teenagers today, but I don't think we need to be worried about them being exposed to open air drug use as much as we need to be worried about them trading Ritalin and other addictive prescription substances at school. So, kids are trading stimulants, they're trading Xanax, they're trading opioids, they're sharing pills at parties, they're potentially dying. We're seeing kids die in overdose from fentanyl-laced prescription pills, counterfeit, fentanyl-laced prescription pills. So young people today face many more dangers than young people faced a generation or two ago when it comes to exposure to highly addictive and highly lethal drugs. So this is the environment that kids are growing up in. When you add to that digital drugs and drugs that didn't even exist before, gaming, social media, online pornography, online gambling, online shopping, basically what you have is like this Pandora's box of highly reinforcing drugs and behaviors that makes all of us, but especially younger people, very, very vulnerable to the problem of addiction.
So that seems like it's a phenomenon for all children and teenagers living in the modern age and developed country, right? You have easy access to pretty much everything and overconsumption of digital products and social media. So what about, just sort of like pressing a little bit on Tenderloin area? We know Tenderloin is the area with the most children, the highest number of children in San Francisco. That's the neighborhood. So I'm just constantly worried about what's that going to do? Will the children feel that's normal, and then they will take it as given, and they will feel, well, maybe if I see those adults doing it, maybe I'll do it in the future.
Yeah, so I can't comment specifically on the Tenderloin area because I've not studied the nature of that area. I've certainly heard of it, but I wouldn't want to make like any specific comments on that neighborhood. What I can say more broadly is that one of the developmental risk factors for addiction that is well known and has been extensively studied is whether or not parents explicitly or implicitly condone substance use, either to have fun or as a coping strategy. And when kids are raised in an environment where their caregivers are using substances and are explicitly or implicitly condoning or approving substance use, those individuals are at increased risk for trying substances and for developing addiction later in life. So that's definitely a risk factor. Some of the protective types of caregiving that have been shown are parents who have a healthy, strong attachment to their kids and who know where their kids are and what their kids are doing. So helicopter parents, and who explicitly or implicitly do not approve of drug use. Those kids are relatively speaking protected. They're less likely to go on to develop a substance use disorder or other addiction.
Yeah, and also I would like to ask you, this is sort of like a philosophical question. Do you think addiction is a disease?
I think that the disease model of addiction is the best model for our time. And what I mean by that is that there are clearly biological changes that occur in the brain when people repeatedly use a highly reinforcing drug or behavior, and those are unique and different from other types of brain changes related to behavioral phenomenon or learning. Specifically, what happens is this disruption of homeostasis, creating this intense physiologic drive to marshal all of our creativity and resources to repeat drug use. And that can be extremely debilitating and even life-threatening. So there is a distinct biological footprint or marker for this phenomenology or behavior that we call addiction. And I also think that we're living in a time when diseasifying social problems is the way to get people help and also garner research dollars to study that. So those are, to me, other very simple practical reasons for embracing the disease model of addiction. One further point is that embracing the disease model of addiction destigmatizes the process, which I think then encourages or potentially encourages people to go get treatment for it, particularly if we build a healthy infrastructure to give people access to treatment. Now, do I think that the disease model is the only lens through which to understand the pathological compulsive overconsumption of substances and behaviors? No. I think that there are philosophical lenses. I think that there are spiritual and religious lenses, which also apply. But I think the best model for our time is the disease model of addiction.
I mean, I always use these two terms sort of like interchangeably, but until recently, I feel people are using them for different purposes between drug addiction and substance use disorder. So are there any true differences between the two terms?
Not really. The language of addiction is in flux, and it can be really hard to know whether people are using these terms synonymously. But in general, the word addiction is the most commonly understood lay term to understand this process of compulsive continued overconsumption despite harm to self and or others, which is a broad definition of addiction. The Diagnostic and Statistical Manual of Mental Disorders, oddly, doesn't use the term addiction, even though it's a really handy term, and I wish they did. Instead, they use something called substance use disorders to connote or be the rough equivalent to what many people, in common parlance refer to as addiction. So the bottom line is that a substance use disorder, and then you replace substance with nicotine use disorder, alcohol use disorder, methamphetamine use disorder, is the medical term for addiction.
From your book, Dopamine, you mentioned successful recovery starts with abstinence. Mm-hmm. So, but then I also see there's a spectrum of treatment, like, going from abstinence all the way to, I don't know whether the other counterpart would be harm reduction. So could you tell us maybe, like, is there a spectrum of approaches or treatment or philosophies to help people recover from drug addiction?
Yeah, I mean, I think the bottom line, when we think about recovery, it's important to remember that there are many ways to the top of the mountain. It's not a one-size-fits-all proposition. I think people generally agree on what recovery looks like. It's not just getting out of the vortex of addictive use. It's also more broadly a way of participating in our communities in healthy and adaptive ways. So it's broader than just related to the substance use. And indeed, I think there's a growing acknowledgement that there's a way to be in recovery while still using substances. So for example, somebody who's been addicted to alcohol could potentially use alcohol in moderation, in which case they're not abstaining from alcohol, they're using alcohol in a way that's not meeting the criteria for addictive use. That's recovery, right? So you don't need to abstain to be in recovery. What you're referring to in my book was specifically about restoring homeostasis in terms of reward pathways. And I was speaking more broadly also about process addictions. So I wouldn't want you to quote me as saying recovery is abstinence or begins with abstinence. Indeed, I also reference in my book that although this restoring homeostasis for most people in recovery begins with abstaining from their drug long enough to restore dopamine homeostasis, I also specifically say that there are some people who it looks like they can't do that. And then they need medications in order to help them restore homeostasis. That's things like methadone maintenance and buprenorphine for opioid use disorder. Further, once homeostasis is restored, as I said, some individuals may be able to go back to using their drug of choice in moderation, right, with appropriate sort of boundaries in place. So it's more complicated than just, oh, you have to abstain, or, oh, you have to take buprenorphine, or abstinence is, the only way to be in recovery. It's more complex than that. And I think acknowledging that complexity is really important. In terms of harm reduction, that term specifically means any intervention that reduces the harm related to substance use. Okay. Or if it's a process addiction related to the process. So a harm reduction intervention includes things like DUI checkpoints, right? Making sure that people aren't drinking and driving. That is a harm reduction strategy. Clean needle exchanges, that is a harm reduction strategy. And by the way, those are both evidence-based harm reduction strategies. So I think that's a really important piece here. Someone can say something is harm reduction, but if there's no evidence to show that it actually reduces harm, then it's not a harm reduction strategy. You can want it to be a harm reduction strategy, but just using drugs in another way or in a certain setting, unless you've shown that it actually reduces harm to the individual and the public, because addiction is a public health problem, then it's not a harm reduction strategy. You can call it that, but it's not a harm reduction strategy until you have evidence showing that it actually reduces harm. Now, clean needle exchanges, we have evidence for that. Making naloxone an opioid overdose reversal agent, we have evidence for that as a harm reduction strategy. We have lots and lots of evidence for methadone maintenance and buprenorphine. These are opioid agonist therapies in the treatment of opioid addiction as an effective harm reduction strategy. In fact, if you look at all of the evidence for interventions for addictions, opioid agonist therapy actually rises to the top of the most evidence-based or among the most evidence-based types of harm reduction strategies, or let's just call it treatment. It's just treatment for opioid addiction. But there are other, types of things that people are exploring which don't have evidence behind them. And so without that evidence, you can't call it harm reduction.
Can you give some examples of those cases where people claim them to be harm reduction, but it's not really showing any true results?
Well, again, I would say that to my knowledge, there is no reliable or robust evidence that safe injection sites reduce harm to the public good. There are publications showing that people who use drugs in a safe injection site are less likely to overdose from those drugs. But to me, that's not really saying much. I mean, you're just basically saying there's somebody right there to reverse the overdose. But what's happening in that neighborhood? What's happening in that town? What's happening in that broader community? Does that safe injection site reduce drug overdoses in the larger community? To my knowledge, there's not evidence to show that safe injection sites do that. So that would make me skeptical about safe injection sites being real harm reduction. Now, maybe I'll be proven wrong. Maybe maybe there are studies that are soon to come out or emerging data showing that in fact safe injection sites help reduce overdose rates, help people get into sustained recovery. I haven't seen that, and so it could be partially my ignorance, but I would want to see that before I would say yes, this is a harm reduction strategy. The other thing that's really important to keep in mind is that context really matters when it comes to the disease of addiction. And you may have an intervention like a safe injection site that's a real harm reduction strategy in one community, but if you try to import that or export that to another community, it might not work, right? And this has been shown to some extent for drug courts as well. You can have a drug court that works really well in Hawaii, but maybe not so well in Portland, Oregon. So those are the things to think about.
So in San Francisco, we know the new, they set up a new safe injection site called the Linkage Center in the Tenderloin area, where inside, I mean, this is based on reports that I read online, inside there are people using drugs. And then there are also people who want to seek help to recover from using drugs. So to me, I'm not trained as a doctor, but to me, to mingle these two groups doesn't make much sense to me.
Mm-hmm. Yeah. So again, I've not visited the safe injection site in California. I really don't know much about it. I haven't had the time to look at it closely, so I wouldn't want to comment on that specific site. But just more broadly, I mean, we do have this concept in addiction medicine of meeting patients where they are. And there are so many barriers to addiction treatment that we just can't wait for people to show up at the Betty Ford clinic, because many people don't have insurance to pay for that, can't afford it, can't get there. A lot of times patients will show up in emergency rooms and be looking for help for addiction treatment, but we don't have a medical infrastructure to help them, right? Or we don't have the know-how. Doctors aren't trained on this. So many barriers to people with addiction getting treatment. So the idea is to meet patients where they actually are. And since they are at safe injection sites, it's actually not a bad idea to think about, well, let's use that as a way to pull people into treatment. But what I would want to see is the data on whether or not that's actually happening. Like, are people actually getting into treatment because they showed up at the safe injection site? That would be really important, I think, to show.
This seems like it's a pretty concrete piece of information we could collect, right? Because although you have 100 people coming in on a daily basis, how many of them really checked into any drug addiction treatment facility?
Well, so it's a lot harder, I think, to actually gather those data than you might think, because typically, the first pass of getting into treatment isn't going to rehab. There are so many obstacles to rehab, payment for rehab being the top one. Rehab's expensive, a residential treatment center. Usually treatment happens at different levels. So the least invasive level is just like an outpatient clinic where you have doctors who treat addiction, and you would go to see one of those. That would typically be the first pass. Or maybe you would go to a mutual help group like Narcotics Anonymous or Alcoholics Anonymous. That's not technically treatment, but it is a proven evidence-based intervention that's been shown to work. So those are the types of things that you would want to look at, not just who's going to rehab, but like, did anybody get persuaded to go see an addiction, medicine specialist? Did they actually go to the appointment? Did anybody get persuaded to go to a mutual recovery? Did they actually go? How often did they go? Did anybody, get engaged to do a higher level of care? If not, was it because they couldn't afford it? Was it because they didn't have that level of care in that community? So there are lots and lots of difficulties with tracking this, because it's not just a matter of what the person is willing to do. It's also a matter of what they can pay for and what exists in terms of the infrastructure to provide the treatment that people need in a way that they can access it. And for people living on the street, accessing healthcare is just hard, right? For a lot of reasons, having to do not just with payment, but just about their ability to make appointments, to show up at appointments, all of that stuff. I mean, in my professional lifetime, which is now spanning about 2.5 or more decades, the Affordable Care Act was a huge shift in people's ability to pay for addiction treatment. Prior to that, if you wanted to, get treated for addiction, you better have a trust fund somewhere. It didn't exist inside the House of Medicine. It was siloed off in these private, kind of rehabs, and really only the wealthy had access. But since the Affordable Care Act, it's now I think it became mandatory on the California Health Insurance Exchange for the 2007 Addictions, Equity, and Mental Health Parity Act. I might be saying that a little bit wrong, but basically that's the act. It said that insurance companies have to reimburse treatment for addiction and mental health disorders, on par with other mental health disorders. And that was huge. So it was 2007, the Mental Health and Addictions Parity Act, and then essentially the Affordable Care Act, that in my professional lifetime was a huge change in people's ability to actually get insurance to pay for addiction treatment, which is huge because it's very expensive otherwise.
Right. For people who have insurance, so that's really helpful. Now their insurance will pay. But for people who are on the street, does Medicaid or Medicare pay for it?
Very hard to find Medicare facilities, although they do exist. But Medi-Cal generally, especially in San Francisco, and again, my knowledge of this, you should really get somebody else who works for the county system, and I can refer you to a lot of wonderful people. But I believe there are pretty good resources in San Francisco for Medi-Cal.
I feel there were two camps when I interview people. One camp said, oh, drug addicts, they've done something wrong and they made a mistake. They need to, they need to toughen up themselves, and they need to take responsibilities for the mistakes that they have made in the past, right? So the accountability camp. Mm-hmm. And the other camp is the very opposite and say, no. Yes, they made mistakes, but they're victims, probably of trauma, probably of like domestic violence, or maybe even if they just make a mistake by accepting a drug from the neighbors, they're the victims of the drugs. And therefore, we can't make them to do anything because that's going to harm them more. So that's like the victim ideology. So I feel neither of them, I don't buy either of them, right. But how do we find the middle ground?
I think the best way to get at this problem is the biopsychosocial conceptualization of mental illness, which I think is the truest grounding of any complex mental health disorder. And what it basically means is that all mental health disorders, and I think addiction is kind of the quintessential example of this, have a biological, that is to say, brain component, right? Physiological, biological component. There's a psychological component that has to do with our life experiences, our innate temperament. And then there's the social piece of it, right? The context, the environment. We're not living in a vacuum. We live in real places, surrounded by real people with vastly different, opportunities and access to all kinds of things, including healthcare. And all of those things play a role. So the environment absolutely matters, right? If you're living on the street, your ability to address any of your health issues, including mental health issues, is going to be compromised by the fact that you're living on the street. On the other hand, even if we acknowledge the disease process and the biological changes that occur in the brain and the fact that agency is hijacked by the disease of addiction, it's not entirely lost, but it's greatly diminished. Nonetheless, people preserve the ability to some extent, once they have a clearer sensorium and they're not in the acute throes of intoxication or withdrawal, to make a choice about what they want to do with their lives. They may be very limited in their capacity to make a choice, but they still, there is that element when people can choose, to do something different with their lives, even if all they're doing is reaching out for help. Mm-hmm. So I think it's all of this together. And whenever we try to like pull out one thing and say, oh, it's just a disease and people have no agency, or we try to say, oh, people have agency and they're blaming other people, that's never going to capture the true complexity of the disease of addiction, which is this complex biopsychosocial disease, which needs a complex biopsychosocial intervention. So I love the AA motto, which is, I am responsible. But even in the context of that motto, AA says alcohol is an allergy. So they're both acknowledging the biological way in which a given individual is at the mercy of a particular drug, while also acknowledging that that person has agency. It may be very limited agency, but they have agency. And on the other hand, we can't then just say, well, blame the person entirely, and like people make their own choices. You make your bed, you lie in it, because that's obviously doesn't capture the reality either, because people have different life circumstances, some extremely challenging life circumstances. And there's a real powerful physiology that hijacks reward pathways that makes it nearly impossible to change our lives when we're in the throes of a severe addiction. So it's not going to be one or the other, right? It's not going to be this person's a victim of their disease, or this person's, moral turpitude, and they just need to pull themselves up by the bootstraps. It's neither of those things. It's this much more complex biopsychosocial phenomenon, which therefore requires a complex biopsychosocial intervention. In medicine and in society more broadly, we love the simple thing. We always want to reduce it down to the simple thing. But when we do that, we're not acknowledging the genuine complexity of the process. And when we leave that complexity behind, we're not going to be able to come up with a viable solution. We have to embrace the complexity. We have to embrace that this is a difficult disease to treat. It's a chronic relapsing and remitting disease. It typically takes years to really go very far down the road of severe addiction. So why on earth wouldn't it take years to get into recovery? Of course it will. Of course it will.
So based on your experience, just now, I think you already mentioned, the successful ones, they take a responsibility. Is that the observation that you usually see in your clinic among all the patients that you treat who are more likely to succeed in terms of recover from drug addiction?
Well, I long ago gave up trying to predict who's going to get into recovery. I've had patients walk through the door who I thought, no way. There's no way this person's going to be able to heal. Their disease was so bad, so many failed efforts, and yet lo and behold, they got into recovery. I've had people walk through the door. I thought, slam dunk. I got this. They got this. No problem. And those people didn't get into recovery. So I don't try to prognosticate anymore. And I would also say that I don't expect people to be able to exercise their agency and autonomous responsibility when they're in the middle of intoxication and withdrawal, which is this vicious cycle of intoxication, withdrawal, drug seeking, intoxication. It's an all-consuming cycle. And when people are caught in that cycle, they can't access their prefrontal cortex, delay gratification, see future consequences, and make informed choices. So many times, by forcing people to abstain for long enough to get their prefrontal cortex back online, in my experience, people with addiction, if we do that, if we force them through some mechanism to get out of that cycle of intoxication and withdrawal, those individuals will then be able to access their choice mechanisms and then actually choose what they want in their lives. And those individuals will often choose recovery. They will accept treatment once they're out of their cycle. So, for example, I've had many experiences in my professional career where interviewing somebody with acute alcohol intoxication in the emergency room, so they're either acutely intoxicated, but still able to have a conversation, or they're in withdrawal. If you talk to that person in the throes of intoxication or withdrawal about whether or not they are interested in treatment for their addiction, the vast majority will say no. If you hospitalize them and give them a period of recovery from that intoxicant, typically, let's say, minimum of a week to get out of that vicious cycle, and then you ask them again, are you interested in treatment and recovery? They will grab at treatment and recovery. They will grab at it. So to say that the whole stages of change model, Prochaska's stages of change, in some ways, it's a very useful model to conceptualize that people have to be at a point in their disease process where things have gotten bad enough that they're motivated to do the hard work of getting into recovery. On the other hand, it's a very pernicious model because it allows us as healthcare professionals and as societies to sort of write people off and say, oh, that person's pre-contemplation. They're not interested, in treatment. You can lead a horse to water, but you can't make them drink. And the truth of the matter is that if you wait long enough for that horse to have enough water or whatever, I'm probably messing up the metaphor, but anyway, the point is, if you wait for that person to get out of the physiologic state of hyperarousal, which is intoxication and or withdrawal, and again, get their frontal lobes back online, many times people will then say, no, I do want treatment. So we're not ourselves. We don't really have access to our choice mechanism when we're chasing dopamine, but a little bit of a break from that can totally change somebody's perspective on whether or not they want treatment.
So does that relate to the mandated treatment or court-ordered treatment, where you sort of grab people at a point when you give them a choice between carrot and stick, either you go to jail or you go to this treatment. So sort of like get them out of that state and sort of like get them the opportunity to a time when they can make a better decision for themselves.
Yeah, I mean, the whole point of, these environments, to put people in environments where they don't have access to drug, is to acknowledge that if they are in an environment where they have access, they will use. They will not be able to not use, and that is their disease. But if you remove them from that environment and put them in a place where they don't have access to drug, essentially what happens is the brain begins to heal. The prefrontal cortex, our decision-making and delayed gratification part of our brain, gets back online. And then people can access their agency and their choice. They can actually see the true consequences of their drug use, which you can't see when you're in it. And then they can make a decision, right? And very often people will then choose recovery. So these sorts of, interventions, as much as rehab gets a bad rap, from pop songs to you name it, I'm incredibly grateful for rehabs, because I have many patients who just won't be able to make it unless they're in this kind of regulated environment. Now, in terms of legal mechanisms to force people into treatment, I mean, what's very odd is that in most of the United States, we have legal mechanisms to force people into treatment for psychotic disorders or manic disorders or people who are acutely suicidal, but we typically can't invoke those when it comes to addiction. And to me, this has to do with the stigma of addictive diseases, because really there shouldn't be any difference. When people are dying from their addiction, well, I mean, they're dying. It's, and again, they've lost agency. When people are manic from bipolar disorder, we will hospitalize them to save them from themselves. So we really need to be able to invoke this mechanism as well when it comes to substance use disorders.
Do we know any evidence from the literature on the effectiveness of mandated drug treatment?
I believe there are studies showing that people who are mandated to AA do as well in AA as people who go there voluntarily. I'll have to look into that to verify that. But certainly there's work showing that one of the most common mechanisms for getting into recovery is through the prison and jail system. Now, what exactly is moderating that, isn't clear. Is it sustained abstinence that gets the brain functioning, that gets people the capacity to choose recovery? Is it something about their easy access in some prison and jail symptoms to treatment? Is it something else about that experience? But I think that's really important, because it does speak to the ways in which the addiction medicine field and the criminal justice field really do need to work together to help people, have their best lives.
So do we have a shortage of drug treatment facilities in California?
What we have is a lack of infrastructure for treatment for addiction inside the House of Medicine. So we have lots of private sort of addiction treatment facilities that have come into being to fill the vacuum that exists inside traditional medical infrastructure. But oftentimes people can't afford those, or insurance companies won't pay for them. And they're not closely linked to that person's other regular, health treatment. So what we really need to do is build a sustainable infrastructure inside the House of Medicine to treat addiction, so that anybody can walk into an emergency room and say, I'm addicted to opioids, or I'm addicted to methamphetamines. Can you help me? And that there's a whole kind of body of work and algorithms and insurance coverage and social workers and medical doctors and, who know how to do that. Just like somebody walks into an emergency room in diabetic ketoacidosis, even a first-year medical student has learned something about how to do that. But even the most senior attending in medicine may have no knowledge of how to treat addiction. And yet, tens of millions of Americans are struggling with addiction.
And I guess my last question is related to religion. So we know of, the number of Americans who go to church regularly is dropping over time. So does faith play a role in the effectiveness of recovery from drug addiction?
The literature shows that people who are actively involved in religious organizations are less likely to become addicted in the first place. So that's been quite consistent. There's also a wealth of literature showing that a spiritual awakening is a very important part of recovery for many people. There are some philosophers and psychiatrists, Carl Jung among them, who hypothesize that the disease of addiction is actually a disease of an impoverished spiritual life, and that to get into recovery, people need to find God or some equivalent. So there's a lot of interesting overlap. I know myself and many of my colleagues are drawn to the addiction medicine field because of this spiritual aspect to it and the philosophical aspect. So there's definitely something there.
Yeah. Well, thank you so much, Anna, for speaking with me. This is really great. Thank you so much.
You are very welcome, and I'm looking forward to our time together.